Steyn. Join me as I do interviews with leaders in the field of artificial intelligence from across the world. We speak about the business relevance of artificial intelligence, and we also speak about the future. Is it to be feared or to be embraced? Please subscribe at my website for updates on future interviews. The idea that we can use modern technology to help others and to secure a better future for our children is close to my heart. My guest today is Kathryn Malherbe, who is doing groundbreaking work in the fields of healthcare and artificial intelligence to combat the scourge of breast cancer, especially in our own country of South Africa. Breast cancer is the single biggest cause of death in women in our country, where an estimated 50% of women will perish from the disease. I was astounded to hear about the amazing work that Kathryn and her team are doing. We spoke about the improvement of cancer detection ultrasound in mammography and how AI technology can vastly improve the accuracy and speed of diagnostic detection. We spoke about the relevance of such initiatives among the rural poor who do not readily have access to healthcare or the advantage of technology. Kathryn is a university lecturer and PhD student, and her affiliations include the Breast Interest Group of Southern Africa, the European Society of Breast Imaging, the American Institute of Ultrasound in Medicine, the Society of Imaging Informatics in Medicine, and the British Institute of Radiology. I invite you to listen in on what is hands down the most interesting AI interview I have done to date. Kathryn references many organizations and initiatives in this talk, and I've added all the relevant links in the comments below.
Joining me today is Kathryn Malherbe, all the way here from Johannesburg, where I am. Kathryn, good morning. Thank you for making the time. You are doing fascinating work. So let me just, before we get going, say the following. I love, and I've said this on other videos, I'm very passionate about AI and where it's going. Also a little scary sometimes, but if it's something that we can use to do good and to help others and to better humanity, then I'm very excited about it. And that's what you're doing. You're working in healthcare, helping people, working particularly in the field of cancer and breast cancer, which is so relevant. So thank you for joining us. What I often do with guests, I say, you've got 2 minutes in the lift with me, and I ask you, so what do you do for a living? How would you answer that question?
So I actually love when people start asking it to me now, because a few years back it would have been an easy answer, but now I'm involved in so many different fields that it's actually quite a myriad of things. So I run a local breast cancer nonprofit. We service over 45,000 women in South Africa. And then I lecture at the University of Pretoria. So my passion for AI, the students can't hear enough of it from me. And I'm always trying to invoke their interest in the field because it's still quite fairly new from an education perspective. And then we recently started our own startup in AI software for breast cancer imaging. We're working alongside TIA, the Tech Innovation Agency, and also Innovation Hub. Yeah.
It's amazing. So you obviously, I assume, started your academic career in the medical field. You're in radiography, if I'm not mistaken. So where did the interest and the combination of AI with medical technology start? How did that happen?
So it was actually a few years back. I've been working in the field for over 15 years, and I kept asking myself the question, why are we missing certain cancers with mammography, and a specific type of cancers, breast cancers? And with this, I actually started collaborating with MIPAR. It's a derivative of MATLAB. It's software imaging actually used more by Microsoft and NASA for life sciences and material sciences. And I actually contacted them to ask, how can we do our own segmentation algorithms for ultrasound images? And this is where the algorithm actually came. And I realized that we can find methods to better improve the detection of cancers on ultrasound, on mammography. And since then, the rest is history, because since then I was so fascinated by how wonderful AI can be used. And funnily enough, in our profession, it's been used for over 3 decades already, computer-aided detection. So it's actually a very old method, but the AI and the deep machine learning that's been added has now come in the past 18 months in our field.
A lot of people don't know it. I mean, AI has been around for, I think, about 60 odd years, and then there was the AI winter in, I can't even remember now, in the 60s and maybe in the 80s. But now with cloud computing and with better computing power, I don't think we'll have a winter again. So this kind of machine learning and image recognition is based on a myriad of data. So I assume if you think of lung scans and what we're talking about today, mammography, it's based on most likely millions of scans worth of data. So where do you get the data from? Is it something you access or buy, or do you produce it yourself?
So for my own, we actually have a few partnerships with Prof Carol and Benn and all the practices that she has in Joburg. So we have access to over 40,000 images for our data set training, which is actually a small amount because the initial CAD systems, the problem that they were feature driven and they're very retrospective in nature. Very limited data is being used for training, and there's very few studies actually yet that's checking from a perspective point of view how the AI is actually relating to histological output. And that's now the step we're going to take, is now to put it in real time in practices to see how accurate it is, because the proof is in the pudding if it does actually work.
I wanted to ask you about the accuracy. Look, I think AI is, or should be, a lot more accurate than humans. But it doesn't replace the medical professional. It aids the medical professional in the diagnosis, because I think experience and sometimes, if you would, intuition still counts. So I'd love to know what the accuracy rate would be. What do you expect it to be? Hopefully as good as possible. What do you think?
So currently our algorithm runs at 85% accuracy. If you look at the most recent studies of AI comparing it to radiologists, there's about a 10% improvement in less diagnostic detection errors, which is actually quite vast. And it's 10% of patients globally. That's a lot of patients that you're actually improving. So initially, these algorithms were used to only differentiate different types of breast parenchyma. But now it's being used actually to reduce false negative rates, pick up missed cancers. And then the extra step that we're adding, we've found a method through grayscale means to actually determine the type of breast cancer. Now, that's never been done before. You need histology for that. So we've managed to find a method with AI to actually give these predictions. And in a South African context, that's huge. There's so many rural clinics without the infrastructure to do on-site biopsies or who have proper software, and this is a method to allow them earlier access to surgical intervention.
You know, and I'm passionate about our country and that we can do so much good for people with this kind of technology. What are the kind of breast cancer rates globally or here in South Africa? So I assume it's at a certain age, potentially more prevalent. But is it like 1 out of 4 or how? Tell us a bit more about that.
So it's quite scary in South Africa. Breast cancer is still the highest rate of mortality and deaths in women. We're talking about millions. And the problem in South Africa is most cancers are picked up late stage because of the lack of infrastructure and diagnostic centers across South Africa. Overseas, it's about 1 in 8. The latest stats in South Africa have it estimated 1 in 2, which seems like a very scary amount, actually. And also what we've noticed in practice is the age has changed. So typically, they would have expected breast cancer to be over the age of 40 years. We're seeing more and more women in their 30s, early 30s being diagnosed by breast cancer. No family history, no specific predisposing risk factors. It's just more and more happening in younger patients.
Is that lifestyle, is it the stuff we eat? What's the reason for that, do you think?
So this is the thing about breast cancer that makes it so fascinating from a research point of view, is that there's no single reason yet that we can point at and say, this is a reason that breast cancer developed. The most common reason is some genetic predisposition, but most patients don't even have that. Other things like lifestyle factors, but lifestyle is for any disease process, hypertension, blood pressure, anything like that is due to poor lifestyle changes. All of these are just associated risk factors, but only about 40% of all patients that's diagnosed with breast cancer actually have a family history or a risk factor. So we usually tell patients that the biggest risk factor is being a woman and the fact that we're in a South African demographic.
So having had children, does that increase the risk? Having, for instance, breastfed or something like that, is that related at all?
So that's actually a good thing. Having more children, miliparity is what we call it. Having had more children, having breastfed reduces your risk. But I've seen patients in practice that were actively busy breastfeeding who developed breast cancer in that process. Breast cancer is the enigma, and there's so much funding going into the research of it because they still try and find a way to improve detection from our diagnostic point of view, but also to improve the therapeutic intervention of breast cancer.
I assume you're networking with other organizations globally because this should be a global effort. I would assume there's UN funding, something like that, because it's so serious.
Yeah, there is a lot of funding. I'm part of BIGOSA in South Africa. That's the Breast Interest Group of South Africa. And then I also affiliate with the breast imaging or radiology groups from overseas, and SIM, the imaging informatics in medicine. Also associate with them. And then there's also Prof. Richard Barr. He's based in Atlanta. He's well known for breast radiology and AI. He's developed already his own methods and own diagnostic methods with it. I met him last year in Melbourne at a congress, and he's actually working with us now in our software. So we can also try and integrate the software from an international demographic, because it doesn't help your being biased about the data that you're testing and only using a local demographic for the testing.
At the end of the day, we all work money and medical practitioners and money as well. But do you find that in international collaboration, there's a bit of a territorial thing, if you would? There's obviously the protection of IP and things like that. Or do you find that there's really a willing collaboration between professionals in this field?
I think there's always an editorial niche around it. Everyone wants their name on any research that's being done. But everyone that I've come across in my profession, internationally and locally, thankfully, most of them are focused on the better good of diagnosing earlier and improving the prognostic rates. But the hope is that if we're starting to implement AI in young SMEs in South Africa, that the focus is not on a cash-driven financial approach, but that it's actually focused on the ethical and also the accountability and for the better good of the patients, the outcome of the patient, not actually the physicians using the product.
I think there's obviously an associated cost with any illness, if you think of whether it's state-funded or not, medical care, the taking up hospital beds and all those things. So there's still a benefit to society and to government and all those things. Tell us how this now works. I assume the mammogram picture, if you would, and I'm a bit of obviously a novice when it comes to these things, is that a digital image or it's scanned digitally and then fed into some sort of a system? Or take us through the process from the actual, I call it a picture or a scan, and then what happens after that?
Yeah. So initial mammogram images, most of the practices in South Africa still use conventional, as in, think about in the movies where they had a red room. We were still taught like that as students, where you had a dark room with the red lights. Some practices still actually use that. I have students now that I'm teaching that are based in more rural hospitals that actually make use of conventional darkroom imaging. But the more practices are now using digital systems. So it's an active detector. It's not a film per se, as we think of X-ray as a film that you put up against the light box and you see it. It's a digital image, and it is actually fed into a PAC system, a picture archiving system. And then afterwards, this post-process image has a few post-processing things. This is where CAD is added, where certain AI measures can be added. CAD is actually not used favorably by radiologists because it tends to be oversensitive in picking up things that look suspicious. So most of the mammo systems have the CAD. Most radiologists avoid it because it's actually just impeding their diagnostic output.
AI then categorize, I assume, because it could, for instance, again, being a man and a novice, forgive me, but it could be a lump that's not cancerous. How will the AI categorize it? Because I assume if it's a lump in the breast, it might need further diagnosis and working with the patient on that. So what, in other words, what comes back to the medical professional? Is there a priority list of sorts, or tell us about that?
Okay, all right. So for some radiologists overseas have actually developed their own little AI flag systems. So the problem for radiologists, there's mass data, mass patient workloads, especially now during the pandemic that they have to go through. So ideally, most of these AI systems have a flag system. So it will pick up and it will prioritize which ones look suspicious according to what it has been characterized or taught to pick up as being a possible malignancy. And then the radiologist will have focus on those, because most X-ray reports or mammogram reports, not all of them are reported in public hospitals. There isn't time to go through all of them. So patients that present with a clinical finding of a mass or something that's picked up on the mammogram, they get priority. Most patients that come for mammography are coming for their annual checks. They have no symptoms. They're asymptomatic. But those patients also have a risk of picking something up that is not yet presenting as a symptom. And this is where AI can pick up. The most common things AI would pick up is microcalcifications, tiny little white specks on the X-ray. And for ultrasound, there's specific features, but some cancers feature benignancy. They look normal on the ultrasound, and a lot of times these end up being biopsied, and then the results is actually a surprise to see, oh, but this actually looked benign, but now when we look at the tissue results, it is actually malignancy. You can see it like a wolf in sheep's clothing.
This topic of cancer is near to my heart because my father had prostate cancer a few years back. Luckily, it was removed and he's still with us, but my mother and her mother passed away in the same month, both from cancer, bone marrow and lung cancer. And and I think it's like most things, we try and avoid it, never think about it, never read about it until it hits your family, and then you don't have an idea. I mean, it's such a traumatic thing for obviously the patient, but also the loved ones and the family. I spoke at a conference last year on AI in healthcare where I spoke about it's almost like customer experience, but say call it patient experience, because it's no longer standing in the queue at the bank and I hope they can help me quicker and more accurate. This is now my life or the life of a loved one or a child. So it is so much more important, you know. So I'm really glad we're speaking about this topic. Kathryn, I want to touch on outlying and poor areas, because I think that the challenge there is infrastructure, internet connectivity and the like. So in a clinic in some far off area, if you would, how do they upload it onto the cloud? Is there some sort of system? I think you made reference to it, but what if there's not infrastructure or connectivity? I assume that's a big problem as well.
So this is the exciting part of the product that we actually developed. So more and more ultrasound systems are being developed internationally that are handheld wireless systems. So it's literally an ultrasound probe the size of a phone, and it actually links to your phone on an app system or an iPad. So we've collaborated with Clarius. It's an overseas manufacturer of wireless ultrasound probes connecting to your phone. It's not these large ultrasound systems that most people know. And we're actually linking it all. Our AI system is actually from NVIDIA. It's a developer kit from NVIDIA, which is literally a box. It can stand on its own. It doesn't need Wi-Fi. It can link with Bluetooth or USB with whatever computer system they have. And this is ideal for the South African setting. If they do have access to Wi-Fi, it can link to our cloud system. It can help to update the algorithm and the machine learning to keep it up to date. But for a South African perspective, the ideal would be what we're trying to approach now is mobile systems that are mobile, can move around, and they're much more cost effective. Because the problem that we have with our South African products is most AI systems are embedded in a specific manufacturer. So you have to have that manufacturer's system to be able to purchase the AI software. And to purchase the AI software, it needs to be typically, this is probably a sales thing, to have a high-end ultrasound machine. You can't use the entry-level machines to be able to use their AI. Overseas, that's not a problem. But in South Africa, this is a problem because most places don't have the infrastructure to use this. And going back to what you mentioned about rural settings, there's a lot of fear and stigma and cultural background stigma associated with breast cancer. I see it in the nonprofit that I run. There's a lot of uncertainty and it's a lack of education. So with our product, we've also developed the Temba app, which is actually purely for patients, education platform and support groups. We have integrated it with a few rural areas, places I didn't even know actually existed in South Africa. I actually had to Google map it when they contacted me. And it's actually terrible to think that these areas are most prone with a high incidence of breast cancer, and they have no education. So they relate their knowledge about it related to cultural information that they have about it. And it's the silliest cultural information that they have, but this is the only reference that they have in the area that they live.
How do we increase the education of people when it comes to this topic?
Well, like with our nonprofit. So we actually affiliated with the Know Your Lemons campaign from overseas. We were actually the first group to bring it in South Africa. It's very tongue in the cheek. So typically, breast self-examination, you get these terrible leaflets and it's very clinical. No one likes to read them and everybody avoids them. It just doesn't look nice to go through. The Know Your Lemons campaign is actually using lemons. So the 12 signs of breast cancer with pictures of lemons. Everyone understands a lemon. And with self-examination, the self-examination process feels exactly like the inner segments of a lemon. A breast cancer feels like a pit in a lemon. It feels like the lobules of the breast feels like a lemon. So we're using that in a South African context. We were thinking of changing the fruit, but I think most people know what a lemon is. So to raise education, to have these nonprofits, we have ambassadors all over South Africa. We're even going now past South Africa, and we have ambassadors in their groups. We're promoting education of them, and then they also educate their peers in their community in a manner most feasible for their community.
I hope that through this video, somebody will say, I need to contact Kathryn about funding. But so I want to ask you, if you don't mind, is it predominantly private kind of corporate funding, or is there also some government funding involved in the work that you're doing?
So for the nonprofit, the first couple of years I funded it myself because I have an absolute passion for breast cancer education. We are registered now with the Department of Social Development. We have more funding from private companies, medical companies that I've worked with in previous, and also a lot of private donors, people as yourself that knew a family member that went through breast cancer. They feel they want to give back or they want to help a family member. But most of our funding is also from donations. We have donations from cancer magazines. We usually have cancer care packages, which we actually have the community come and pack packages. It's actually so wonderful. Like the mom affected by breast cancer and the daughters would come on the day and they would pack packages for other women affected by breast cancer. Adcock Ingram also once helped us with products. We add products, vouchers. And then also I published a tiny booklet, a breast cancer survivorship booklet, which explains very basic layman terms, what is breast cancer? Because no one explains this to the patient. We are the faces they see when we say you have breast cancer. We throw them into a treatment regimen and they have no idea what they're going to go through. They don't know what breast cancer is. They don't know what chemotherapy or radiation therapy is. So I made a very simple little booklet that explains everything in layman's terms. So they just have an idea what to expect going forward.
It's important. I assume many people who will worry about, well, all kinds of illnesses, but because they have no idea what's going to happen next. Stigma is an important topic that you've mentioned, but we hear horror stories about chemo and how sick it makes people. I mean, I saw it firsthand with my mother and hers. So I think people then rather do a bit of an ostrich head in the sand thing. So let's hope it goes away. Right? And I think knowledge would hopefully alleviate the fear. So it's a great thing that you're doing that. Do you also work with other cancer-related organizations like Cancer and others?
Yeah, Pink Drive and Cancer, and then also Prof. Carol Ann Benn, her affiliation. We also work with them. I write articles for their popular press and Buddies for Life. So I write articles a day in the life of a mammographer, because there's a lot of stigma involved with us doing the mammograms. I'm sure we've all seen funny memes and cartoon pictures about mammograms or manograms. And as funny as it is, there's a big fear associated with going for your mammogram. And it's also, I was writing these articles to show them that the funny thing about mammographers is not all radiographers specialize in it. It's a specific type of person. You have a much more personal affliction to your patients. You are a type A personality, which I am most definitely a type A personality, because it's a very specific type of x-ray that's being done. And training the students that I'm training now in mammography at the university, my key focus is actually to inborn them with compassion for their patients, because that is the most important thing. And you actually develop relationships with your patients. I have relations with my patients from many years ago who were diagnosed. We kept contact, we followed up, and it's wonderful to be part of that journey of a patient in our profession.
It's so easy to forget that it's a calling, if you would, because you are working with people. And I know, there's the commercial pressure, and I used to go to a medical practice where you felt like you were on a conveyor belt because you had 15 minutes. And I sometimes felt that before I explained to the doctor what was wrong, he or she would already write me some antibiotic or something like that, because I had to get out as quickly as possible. But that was just a general visit. I think if it's life-threatening, so much more the need for compassion and understanding. What about other female-related illnesses like, for instance, ovarian cancer and others? Do you know that people are using this technology also, those kind of illnesses?
Not yet in the field of imaging. I did present a training education for aesthetic medicine with Dr. Ricky Smith. She's a well-known aesthetic practitioner in South Africa, and we were starting actually to train the local and international doctors in how to use ultrasound for skin analysis. So this is actually a possible field for AI to actually do skin analysis, because most patients that go for Botox or fillers, they're literally looking at the aesthetics of the patient saying, okay, you need this or that. But if you can actually integrate AI in it, there's a myriad of possibilities for it. And on that day of the lecture, there was actually a few specialists in gynecology that mentioned, but this is actually something we can use for imaging method. For prostate cancer, there is AI being used. It can actually grade the type of prostate cancer. It's just finding a person passionate about that field, integrating with someone in the field of AI and DML, and then going forward with it. Yeah.
Hopefully this is a clarion call to the viewers of this video as well. And obviously I'll add all your links and social media and stuff so people can be in touch with you. Before we end off, the other thing, I know you mentioned on your profile ethics, because data and privacy and if you think of it's such a personal thing now of your results being sent in the cloud. I hate that word because it sounds like it's just going somewhere, but we know it's just a computer somewhere else. But it's such a private thing. So how do you address the privacy and then the ethics related issues with the work that you're doing?
I'm laughing now that you mentioned in the cloud. I'm thinking of my father-in-law. He always says he looks up to the skies like it's in the cloud, which isn't really how it is. But a lot of people think of it. It's actually a terrible word association. It's in the cloud. It's not in a cloud.
And it feels like you've lost total control and other people can look at it. And it's not true. It's not actually more secure than saving your data on premises, you know?
Yeah. So it's actually interesting. I read a white paper that was written by Prof Pillay from UP. She's the head of computer science. She wrote a white paper for ethics in AI in South Africa, which is the first ever that a policy was drafted for South Africa. There's a lot overseas. The European Parliament resolution, affiliations with tort law and criminal law. But in South Africa, it has a very interesting extra demographic, because not only are we looking at the ethics from a socio-economic and legal point of view, but we're also looking at the socio-economic demographic in a South African context, because there will be inequality of jobs. We already have a problem with job creation. Who will be accountable for the financial gain that's received from it? And we don't have a policy that actually states the minimum security requirements for AI to be used. What is the appropriate security measures to have? What firewalls to be used? All of this still actually needs to be drafted for the South African context, because all of our software or SME companies are using international policies, but there's so many more young SMEs being developed in South Africa with AI software. We need a local policy draft actually for that, for security issues and ethics. For us, okay, obviously there's the POPI Act, Protection of Personal Information, and then when any data is fed into an AI system, there's the immediate anonymizing of the patient identifiers. So it's only having key focus on the image, and it loses its association with the patient data. And then obviously having appropriate security measures to have a few security walls before actually having access to the cloud system. And this actually needs to be stated clearly in the software design. So if there's ever any inquiry about the security issues, or when an ethical issue comes up, you actually have proof to say, but these are the measures that we use, and we are following the appropriate POPI acts, but we don't have a AI Act, if I can say like that, in South Africa to actually relate it to.
The last question, and I've got so many more, so we're going to have to do a follow-up call sometime, Kathryn. Maybe it's a stupid question, I don't know. The topic of bias in data, especially with facial recognition, and given what's happening in the US, it's a hard and relevant topic. Is bias a problem when it comes to this kind of technology? It's not facial recognition, but so talk us through that, maybe.
Definitely. So for any AI system, the AI and the DML is only as good as the data that's fed into it. And the problem is most data training sets are from one practice, one group of demographics, which makes it a bit biased, because you're actually trying to learn it, an algorithm based on you want this output specifically. You're not allowing it to make its own association. You're trying to limit it, which can be a bit biased. So we need actually a system to say that if we are feeding images like breast cancer images into a system, we actually need a wide variety of images. So with our algorithm, we're actually training it on what we would call bad ultrasound images and good ultrasound images. So not everyone is an expert in imaging. So some might have a low resolution system with poor image quality, and someone will have the best high resolution imaging being used. And we're trying to train the algorithm to read both, to reduce that bias, because you're not always going to have perfect images being fed into the system. And it should be able to distinguish between these to reduce the bias in the imaging.
You're doing good work, you're touching lives. It's as I say, it's not just commercial and banking and kind of, because I think AI makes things more convenient for us, but when you work in saving lives, bettering the quality of life, I've got huge respect for it. So I hope that people watching this video will be in touch with you, that there will be networking, potentially funding opportunities. I appreciate your time. And this was a fascinating conversation. Thank you so much.
Thank you. I hope everyone can also hear the excitement that we have working in this field. Everyone that's met me in person knows I exude a passion for breast cancer education. And now to be able to bring it into our profession with AI imaging makes me even more excited and more privileged to be part of the journey, especially in South Africa.